population, and it's one of the leading causes of maternal mortality worldwide. And according to the latest report by the National Committee for the Confidential Inquiry into Maternal Deaths of South Africa, embolism has now increased to be the 5th most common cause of maternal death. And this may be explained due to changing maternal demographics, such as the increasing global rise of obesity, increasing maternal age at conception and delivery, as well as due to rising surgical delivery rates. And it also contributes to maternal morbidity and significantly to healthcare costs. So a thrombus is an aggregation of fluid into a solid clot. It's composed of fibrin, platelets, and cells, and it can partially or entirely occlude a vessel. It can further develop or extend into the same blood vessel or dislodge into smaller clots, forming emboli. And these smaller clots then travel through the vasculature to lodge in downstream vessels. 80% of venous thrombotic events are deep vein thrombosis, and 20% of them are pulmonary emboli. Hemostasis is a physiological process that leads to cessation of bleeding from a blood vessel. It involves multiple interlinked steps, such as vascular endothelial damage, which can either be due to mechanical trauma to a blood vessel through surgery or trauma, or it could be from biochemical damage, such as through inflammation or infection. And then fibrin is then generated through the coagulation cascade, after which a clot is formed. The last step is fibrinolysis, which is gradual degradation of the clot to restore normal blood flow as a blood vessel heals. With the physiological changes of pregnancy, a pathological thrombus becomes increasingly more likely because these changes, as described in Virchow's triad, venous stasis, endothelial damage, and hypercoagulability tend to be more pronounced in pregnancy. So why exactly are pregnant patients prone to VTE? This is because pregnancy and the puerperium are characterized by changes that favor coagulation over fibrinolysis. And these all occur in the pathway, these occur in all the pathways of the coagulation cascade, such that there's an increase in clotting factors, a decrease in circulating anticoagulants, as well as reduced fibrinolysis. And if we look at these changes as they relate to Virchow's triad, there's increased thrombin formation, and that is due to reduced activity of protein C and S, increased concentrations of procoagulants, as well as reduced fibrinolysis through, for example, the reduced activity of tissue plasminogen activator. And with endothelial damage in pregnancy, there's damage to the pelvic vessel due to a normal vaginal delivery or surgical trauma, or there could be endothelial inflammation and secondary damage due to conditions such as preeclampsia. With venous stasis, there's reduced venous blood flow due to pelvic vein compression by the enlarging uterus, as well as by progesterone-mediated venous dilatation. This then leads to increased lower limb venous pressures and the likelihood of a VTE. There's also reduced mobility, which is associated with pregnancy, either due to pain and discomfort, lethargy, weight gain, or certain beliefs of bed rest or rest during pregnancy. So the goal of this hypercoagulability of pregnancy is really to prepare for the hemostatic challenges of pregnancy. It's to prevent hemorrhage during childbirth and in the weeks following the pregnancy or the delivery. But obviously a side effect of this is that there's an increased risk of thrombosis. This hypercoagulability occurs from conception and only returns to normal values or to normal between 6 and 8 weeks postpartum. And the risk of VTE is said to increase from the time of conception. There's conflicting data regarding the period of highest or regarding the incidence in the antenatal period, but the highest risk is agreed to be at the time of delivery and postpartum, as approximately half of VTE events occur in the first 6 weeks postpartum. And this might be explained by the increased immobility and endothelial damage associated with delivery. So pregnancy-related venous thromboembolic events, as we said, are important preventable causes of morbidity and mortality. Therefore, thromboprophylaxis provision is key, and it has been proven as such. It may be pharmacological or mechanical. Pharmacological therapy plays a crucial role in preventing and managing VTE events. And in medical and surgical patients, it has been shown to reduce the risk of VTE by 60 and 70% respectively. And this is outside the obstetric population. So it's also assumed to also substantially reduce this risk in obstetric patients. However, because the risk or the absolute risk is low, risk stratification is required to determine which patients will require pharmacological prophylaxis. And the risk of bleeding should also always be evaluated prior to prescribing these agents. So a significant proportion of women with fatal and non-fatal VTE will have an identifiable risk factor. And as we said, identifying these women is crucial if we want to reduce fetal and maternal mortality. The advice is that all women should be risk stratified at their booking visit to identify any pre-existing risk factors for VTE, as well as in the antenatal period, either when admitted to hospital or when confined to bed rest or prolonged immobilization, such as during air travel, as well as in the postpartum period. And then patients may be classified as high, intermediate, or low risk, depending on the number and the nature of their risk factors. This table just outlines some of the risk factors to consider when assessing women. It could be pre-existing factors such as a personal history of a VTE or a personal history of thrombophilia, certain medical comorbidities such as SLE, as well as HIV with an unsuppressed viral load and a high CD4 count, which is important in our setting. Then there may be other factors as well related to family history, the patient's BMI, and so forth. Then there may be pregnancies associated or factors associated with the current pregnancy, such as preeclampsia, multiple pregnancies, and so forth. There's also what is called transient risk factors, and these are risk factors that are that resolve after they've provoked the initial VTE, such as recent surgery, or a patient who has hyperemesis, which then resolves as the pregnancy progresses. So an example of how to assess such patients in the antepartum period is by asking 3 questions or a number of questions. The first being whether or not there's a personal history of VTE. This is because this is the most important risk factor. And it's said that 15 to 25% of all VTE events are recurrent events. And this history can either be of a single or multiple previous events. It's also important to establish if these events or this prior event was provoked or unprovoked. And by being provoked, it means if it was associated with certain risk factors such as surgery, immobility, or pregnancy, or estrogen therapy. And this is said to have important prognostic and treatment implications. For example, patients with provoked VTEs and those with persistent risk factors have a higher risk of occurrence. And if, for example, a VTE was provoked by major surgery from previously, it's said to have a low risk of occurrence or recurrence in the current pregnancy. So antenatal prophylaxis may be omitted if there are no other risk factors, as opposed to a VTE event that was either provoked to, for example, estrogen therapy or that occurred in the previous pregnancies. This has a higher risk of recurrence, and therefore antenatal prophylaxis will be required. The second most important risk factor is either a personal history of thrombophilia or a first-degree family history of thrombosis of thrombophilia. And again, these thrombophilias can be classified into high, moderate, and low risk, depending on their absolute risk for initial or recurrent venous thrombosis. Inherited thrombophilia are rare, and these are due to genetic mutations that impair the coagulation cascade. And acquired thrombophilias, for example, are antiphospholipid syndrome. And here in this table, we just have a list of the different thrombophilias that may be encountered in pregnancy with those that are said to be intermediate and high risk, the recommendation is that they should require antepartum and postpartum prophylaxis. In terms of screening for thrombophilia or these thrombophilias, universal screening is not cost effective, so it's not advised. And wherever possible, laboratory testing should be performed at least 6 weeks after a thrombotic event, outside of pregnancy and when the patient is not receiving anticoagulation or hormonal therapy because of the effects of these states on the results of the tests themselves. So for the acquired thrombophilias, if we look at antiphospholipid syndrome, we test for antibodies. If, for example, there's an unexplained venous or arterial thromboembolism, or if there's a history of fetal loss or 3 or more recurrent spontaneous miscarriages. The American College of Obstetricians advise a selective screening strategy. For example, if a patient has a personal history of VTE with or without a recurrent risk factor, or if the patient has a first-degree relative with a high-risk thrombophilia. Whereas the Royal College advises screening for, or it says that women with a prior VTE should be considered for thromboprophylaxis, and then testing will not then be required because they'll be on thromboprophylaxis anyway. But then they do advise that testing should be reserved in cases in which results are likely to have an impact on the management. For example, if a patient is diagnosed with antithrombin deficiency, this will then alter the dose of antithrombin, of the dose of thromboprophylaxis that they will require. And we'll talk about that at a later stage. Then the third question is to now check or now assess if there are any other additional risk factors present. The American Society of Hematology advises to consider prophylaxis only if there's more than one other additional risk factor present, except for the previous 2 conditions mentioned, while the Royal College uses the thromboprophylaxis risk assessment score, which can be a bit intimidating when you first look at it, but it basically divides the different risk factors into 3 categories, the red being the highest risk, and the orange being intermediate risk, and yellow being lower risk. I won't go through the different conditions, but as we said, a previous VTE is one of the highest risks for VTE. This is just a continuation of the list. And so if the total score, according to the RCOG guideline or recommendation, if the total score in the antenatal assessment is 4 or more, then thromboprophylaxis is advised at the time of the screening or at booking, and it should be continued up to 6 weeks postnatally. And if the score is 3 or the patient has intermediate risk factors, then thromboprophylaxis is recommended from 28 weeks gestation up to 6 weeks post-delivery. If the score is less than 3, then the patient is reassessed postnatally or at a later stage if the circumstances change. But in the postnatal period, similarly, as well, if they have a high score at the time of assessment, then they will get thromboprophylaxis for up to 6 weeks. If they have a score between 2 and 3, they will get it for 10 days. And if they have a score less than 2, then they'll only be reassessed if circumstances change. So while the scoring system, such as the one advised by the Royal College, is designed to streamline the process of identifying patients who require thromboprophylaxis, there are some limitations. The 2018 UK equivalent of a Saving Mothers report highlighted that there's clear evidence that doctors and midwives find the existing scoring system difficult to apply consistently in practice. And they also saw a need to develop a tool that makes risk assessment scoring simpler and more reproducible. And similar sentiments are also were also shared by local experts in 2018, who said, there are several guidelines that propose risk assessment scores, but in the absence of randomized control trials, there's no evidence for complex clinical scoring systems. And the use of, or the appropriate use of prophylaxis should depend on identifying patients who are at risk. And in this article, they conclude to say that, risk assessment should begin early in pregnancy and in the postpartum period. High-risk patients should be managed in conjunction with a hematologist, and antepartum prophylaxis should be initiated as early as possible in pregnancy. And then they also sort of advise the same duration of thromboprophylaxis as the RCOG does. And they also say the use of mechanical prophylaxis can also be considered in patients at high risk of bleeding. Now, moving on to some forms of thromboprophylaxis with non-pharmacological methods in addition to mobilization and advising the patient to stay hydrated. We have compression stockings, or the so-called thromboembolic deterrent stockings, TED stockings. These work by exerting a pressure gradient on the lower limb, which is highest at the ankle and decreases superiorly. They may be used alongside pharmacological methods or in isolation. They're generally recommended during prolonged immobilization. Contraindication to their use include allergy to the stocking material, if there's a local skin complaint such as a cellulitis or dermatitis, or if there's suspected or confirmed peripheral arterial disease or significant peripheral edema. And this figure here just explains or tries to explain how it works. In the first section in A, this is a lower limb or the venous system of a lower limb without the TED stockings, where there is unilateral flow of blood that leads to peripheral edema, and the valves are also not functioning well. Where with the use of the stockings, there's reduction in this biventricular venous flow. Peripheral edema is much less, and the valves work much better when compared to without the stockings. And then with the pharmacological methods, we have heparin, and both unfractionated heparin and low molecular heparins are safe to use in pregnancy, but the low molecular heparins are the drug of choice in most pregnancies. These are large animal-derived polysaccharides that don't cross the placenta because of their molecular weight. They activate antithrombin, which then inhibits factor 10A and thrombin, and they are dosed according to the maternal weight. They're administered subcutaneously, generally as a daily dose for prophylaxis, and their onset of action is 60 minutes. Here is a list or just a few of the ones available for use. In our setting, we have enoxaparin, also known as Clexane, and these are the different dosing regimens according to the weight of the patient. So low molecular heparins are renally excreted, and dose adjustment may be required in renal impairment. And when it comes to monitoring for effect, in view of the physiological changes that happen in pregnancy, the South African Society of Hematology and Hemostasis and Thrombosis recommend that regular anti-factor 10A measurements must be done, especially in women at extremes of weight with renal disease or with severe preeclampsia. And just a note, unfractionated heparin may be used in the stead of low molecular heparin if there's significant renal dysfunction and if a shorter period of anticoagulation or urgent reversal is contemplated, such as in the peripartum period. So again, low molecular weight heparins are favored because their risk of adverse events or adverse effects is minimal. And the most commonly reported side effect is a skin reaction. But unlike unfractionated heparin, they don't interfere with platelets, so the risk of heparin-induced thrombocytopenia is much lower. There is, however, a theoretical risk of osteoporotic fractures with long-term use, which is also much lower than seen with unfractionated heparin. But this is rarely a consideration in obstetric patients because treatment courses are usually confined to pregnancy and the puerperium. And the low molecular heparins are safe to use in breastfeeding because oral absorption is negligible. Where another alternative to heparin is required, for example, in a few patients who experience significant side effects or true allergy, fondaparinux is another option. It's a synthetic inhibitor of factor 10A, binds to antithrombin as well and neutralizes the effect of factor 10. And unlike the heparins, it has no effect on thrombin. So it has a negligible impact on platelet counts and therefore a low risk of heparin-induced or no risk of heparin-induced thrombocytopenia. It is administered subcutaneously at doses of 2.5 milligrams per day in all trimesters. But data on its use in pregnancy and breastfeeding are limited, although reassuring. And due to its lower molecular or high molecular weight, there's conflicting findings regarding its placental transfer. It doesn't have any known antidote, and it requires a longer period between prophylactic dosing and administration of regional anesthesia. So moving on to other pharmacological anticoagulants, vitamin K, or warfarin being one of them, this group works by inhibiting the synthesis of vitamin K-dependent clotting factors and protein C and S. Its use in pregnancy is really mostly reserved or exclusively reserved for those patients with mechanical valve replacement. And furthermore, it should be limited to the second and third trimesters to minimize exposure during organogenesis and delivery. It may be used during breastfeeding, and excretion into breast milk is minimum. But warfarin is known to be associated with teratogenic effects, especially in the between the 6th and 12 weeks of gestation. In addition, there is an increased risk of miscarriage, prematurity, fetal bleeding at any time during the pregnancy. And the congenital abnormalities associated with its use can occur in all pregnancies. So detailed counseling, ideally preconceptually, is essential prior to initiating patients on it. Other pharmacological anticoagulants to consider, the non-vitamin K oral anticoagulants or the direct oral anticoagulants. These are direct inhibitors of factor 10 and thrombin. An example of them is rivaroxaban and apixaban. There's an increasing favor of their use in the non-obstetric population because of improved safety profiles and comparable efficacy to warfarin, as well as no need for INR monitoring due to their more predictable pharmacokinetic profiles. But they are contraindicated in all trimesters of pregnancy due to an incomplete understanding of the associated risk factors and concerns from animal studies. Just to mention a few special populations to consider. So in patients with antithrombin deficiency, as we earlier mentioned, so it's important to remember that heparin acts via activation of antithrombin, and thromboembolism may still occur despite patients being on adequate thromboprophylaxis with low molecular weight heparins because of their reduced efficacy. So such patients may then need to be put on higher doses of prophylactic low molecular weight heparin. And in addition, some laboratories add antithrombin when testing for anti-factor TNA. So it's important to note that values may be then unreliable in patients with antithrombin deficiency. And as such, patients may need antithrombin supplementation in pregnancy, which is not available in South Africa. And then testing their effect or the effect of low molecular heparin would then need to be done with alternative laboratory methods. With antiphospholipid syndrome, if a patient is diagnosed based on a previous thrombosis and the laboratory confirmation, they will be on lifelong anticoagulation when they begin their pregnancy. But in those patients who are diagnosed based on poor obstetric outcomes, the optimum thromboprophylaxis is less clear. However, the general recommendation is to continue low molecular weight heparin antenatally and 6 weeks postnatally. And in those patients with mechanical heart valves, as we mentioned, warfarin is more effective at preventing maternal complications such as valve thrombosis, but it carries a higher risk of fetal loss. The alternative in such patients would be to use a high dose of low molecular weight heparin and institute anti-10A monitoring. This would pose a lower risk to the fetus, but a high risk to the mom. But anyway, these very high-risk pregnancies are ideally managed by a specialist multidisciplinary team with care, better started preconceptually. And then looking at the peripartum period, so women should be advised to withhold their anticoagulant dose in the event of bleeding or if they have any signs or symptoms suggestive of labor. The lower molecular heparins may be partially reversed with protamine sulfate if required, although this is rarely indicated if they are taking prophylactic doses. And if cesarean delivery is preferred and the patient is on warfarin, then if the patients are on warfarin and they're going to labor, cesarean delivery is preferred. And such patients may also need reversal if their INR is high. And although antenatal prophylaxis itself is not an indication for induction of labor, a planned elective birth may be beneficial in order to optimize the anticoagulation-free interval around labor and delivery. And in terms of regional or spinal and epidural anesthesia, this is recommended in the 12 hours following a prophylactic dose of low molecular weight heparin due to the risk of a spinal hematoma. And these agents should be started 4 to 6 hours after removal of the epidural catheters if used. And in cases where an extended epidural anesthesia is required and for example, Clexane is restarted in the interim, the epidural catheter should only be removed 12 hours after the last dose of the heparin, the low molecular weight heparin is given. And it's recommended that neurological monitoring be done for a minimum of 12 hours, but ideally for 72 hours after neuroaxial blockade to ensure that there are no complications that may result from a spinal hematoma. And in the postpartum period, again, every woman should have a repeat VTE risk assessment. And, it's important to also assess for the risk of bleeding before starting pharmacological thromboprophylaxis. And prophylactic low molecular weight heparin may be started or restarted 6 to 12 hours post-delivery. And then the duration of the prophylaxis will then depend on the individual patient's risk profile. And if we now look at acute venous thromboembolism in pregnancy, so during pregnancy, the clinical presentation might vary, and not all patients will present with classical symptoms. And it's said that with DVTs, most are confined to the deep veins of the lower extremities and are located in the iliofemoral veins or in the iliac veins without involving the calf veins, as is seen in the general population. And 30 to 60% of women with a DVT will have a coexisting silent PE, while 70% of those with a PE will have clinical evidence of a DVT. So signs and symptoms will then vary depending on the site and degree of venous occlusion. And a VTE should be expected if a patient presents with leg pain and swelling, dyspnea, tachypnea, tachycardia, chest pain, hemoptysis, or collapse. And as we said, clinical diagnosis is difficult without testing and is only confirmed in only 10% of cases. And certain scores or assessment scores that are used outside of pregnancy, such as the Wells score, are unfortunately not used in pregnancy as they're not validated. After clinical examination and assessing, the stability of the patient, some investigations that can or should be done include baseline blood investigations such as a full blood count, coagulation studies, renal and liver function tests. And then with the question of whether or not we should do D-dimers in pregnancy. So D-dimers are fibrin degradation products that are released during thromboembolism. And their measurement is often incorporated into diagnostic algorithms for VTE outside of pregnancy. But this has been supported by certain studies that show that if you use D-dimer in certain algorithms, it negates the need for further imaging, such as with CTPA, and thus reducing unnecessary radiation exposure. But the problem with D-dimers in pregnancy is that their levels increase due to the physiology of pregnant. They increase with the increasing gestational age. They may also be affected by multiple gestations, cesarean delivery, certain pregnancy complications such as abruptio, preeclampsia, or sepsis. And although a negative D-dimer may be reassuring, a positive D-dimer is of little value because the levels are expected to be high anyway in pregnancy. So both the ACOG and RCOG recommend against its use. Just on the left is an example of one of the algorithms that are used outside of pregnancy and in pregnant populations with incorporation of the D-dimer test. Other investigations that can be done include an ECG if a patient clinically presents with symptoms suggestive of a PE. Up to 41% of women with a PE will have ECG changes, and the most common findings being T-wave inversion, the typical S1, Q3, T3 findings, as well as right ventricular strain. And the other benefit of an ECG is that other cardiac causes or other possible causes of chest pain, such as cardiac causes, may be detected. And then another investigation to do is a chest X-ray, which is unfortunately normal in over 50% of patients with an objectively proven pulmonary embolus, but it is helpful in identifying other differential diagnoses such as pneumonia or pneumothorax. And in a PE, some abnormal findings that can be seen on chest X-ray include a pleural effusion, lung infarct, atelectasis, and so forth. And the fetal radiation dose associated with a single chest X-ray is negligible. So importantly, as none of these tests that we've mentioned are diagnostic, whenever a woman is suspected of having a DVT or a PE, they should be initiated on low molecular weight heparin until the diagnosis has been excluded using diagnostic imaging. With suspected DVT, the initial diagnostic test is compression ultrasonography of the proximal legs, or Doppler ultrasound of the legs. It has a high sensitivity and specificity in diagnosing proximal thrombosis. And if it is positive with clinical features of a PE, further imaging is not required, as the treatment will be similar and the radiation exposure from a CT, for example, will then be avoided. But if it is negative and clinical suspicion is low, then the anticoagulant treatment can be safely stopped. If it is, however, negative, but there's a high level of clinical suspicion for a DVT, either the thrombus may be inaccessible to the modality used, such as if it's in the iliac vessels, or it may have already embolized, and further imaging can be instituted to visualize the pelvic vessels, such as using Doppler ultrasound, CT, MRI, or venography of the iliac vessels. And if there's also a high clinical suspicion for a PE, but a negative ultrasound scan, treatment should be continued and further chest imaging is then required. So a normal chest X-ray prior to a VQ scan improves the likelihood of a definitive result, and many other conditions can cause perfusion defects, such as the presence of a pneumonia and local bronchospasm. So if the chest X-ray is abnormal, a VQ scan is unlikely to provide with a definitive diagnosis, so then a CTPA would be done. But if the chest X-ray is normal, either a VQ scan or a CTPA can be done. And the choice of scan is made considering the local availability of the test, maternal and fetal risks, as well as discussion with a radiologist. A CTPA might be more preferred because of its better availability. It's found in most hospitals and often operated throughout the whole day. And it's also preferable because of its ability to identify other pathologies that the VQ scan will not identify. It's, however, associated with a more significant maternal radiation risk. And radiation doses of up to 20 milligrams to maternal tissue increase the likelihood of the woman having breast cancer. And these are much higher than those provided by a VQ scan. In terms of which one is more sensitive and specific, the studies that have been done comparing the two for the detection of a PE in pregnancy have found comparable negative predictive values with no difference between the number of positive tests, non-diagnostic tests, or normal scans. And looking closely at the radiation risk. So for the fetus, the radiation exposure for both tests is considered low and below the threshold for teratogenicity, fetal growth restriction, and fetal death. There is, however, a small increased risk of childhood cancer with both of them, but more commonly seen with VQ scans. And for the woman, as we said, CTPA radiation exposure is very high, and an exposure of only 10 milligrays to a woman under 35 increases her lifetime risk of breast cancer by 13.6%. So the VQ then would be, preferable or chosen in younger women or with women who have a history of breast cancer or who have already undergone a previous chest CT. And to further reduce, if VQ scan is not available, and to further reduce the radiation exposure to the breasts, bismuth shields can be placed over the patient's breast to reduce the risk by 20 to 40%. There are newer techniques. These include VQ SPECT, which is ventilation and perfusion single photon emission CT. It provides multiple 3D images with much better quality, speed, and improved sensitivity than with the traditional VQ scan. And as such, the European Association of Nuclear Medicine recommends that this should be the new gold standard for diagnosing PE in all patients. However, it hasn't been fully evaluated in pregnancy, and it's not widely available. Other tests, MRI of the pulmonary vasculature, but like the one above, this still requires further evaluation for safety in pregnancy. Now, looking at how we would manage a patient diagnosed with an acute venous thromboembolic event, starting with unfractionated heparin, this is preferred in unstable patients. Patients who are presenting with a massive PE with shock, hypoxemia, or right ventricular dysfunction, or in situations where delivery or surgery is required. And it's also preferred because of its rapid onset of action. It's easy to adjust doses, it's easily reversible, and there's a widespread clinical experience of its use in these scenarios. It can be administered by one of two alternatives, either starting with an IV loading dose followed by subcutaneous doses every 12 hours, or giving it as a twice daily subcutaneous injection with doses adjusted to maintain a therapeutic APTT. So there are several acceptable protocols. The one described above is the IV administration, where you give a loading dose of 70 to 100 units per kilogram, followed by a continuous infusion of 15 to 20 units per kilogram per hour. And then you measure the APTT 4 to 6 hours after the loading dose, and then every 6 hours after any dose change. And then once the APTT is in the therapeutic range, you do the measurements daily. And if IV heparin is maintained, IV heparin is usually maintained for about 5 to 7 days, after which it's then converted to subcutaneous heparin once the patient is more stable. But due to the high risk of heparin-induced thrombocytopenia, it's advised that protocols be monitored every 2 to 3 days from day 4 to 14 or until the heparin has been stopped. Then again, a quick mention of the lower molecular weight heparins. So they are the treatment of choice for treating stable patients. And the dose is calculated using the patient's booking or early pregnancy weight. And the RCOG recommends clexane given at 1 milligram per kilogram twice a day subcutaneously. So there was a study done, or Cochrane review of 22 studies done comparing the efficacy of low molecular heparin with unfractionated heparin. And it found that low molecular weight heparins were superior as it had lower rates of VTE recurrence or extension, It was associated with less major hemorrhage during the initial treatment, with an overall lower mortality. And as we mentioned before, there's decreased interference with platelets, with a lower risk of heparin-induced thrombocytopenia. And anti-TENI activity measurement and dose adjustment is said to be controversial. The ACOG recommends routine measurements, like the South African body, as we mentioned earlier on, with prophylactic doses. But the RCOG recommends testing only if the woman is at extremes of body weights, either underweight less than 50 or significantly overweight or obese, or if there is renal impairment. And then others, such as the American Society of Hematology, have concluded that routine monitoring is difficult to justify, so they don't recommend it. And then the other option is thrombolysis, which should be considered if there's hemodynamic compromise. And evidence from randomized controlled trials suggests that if used with heparin, thrombolysis aids in more rapid dissolution of the emboli. It restores the pulmonary circulation by improving pulmonary hypertension. However, there are no effects, beneficial effects on mortality. And case reports on the use of thrombolysis during pregnancies reported fetal death rates of 1.7%, non-fatal maternal bleeding of 2.9%, as well as abruption and preterm labor. And if thrombolysis is, however, contraindicated in an unstable patient, then the option of thoracotomy and surgical embolectomy can be considered. However, this embolectomy is seldom indicated, and there's very little experience of its use during pregnancy. Other measures that can be used for a patient who's been recently diagnosed with a DVT, for example, are limb elevation, the use of graduated elastic compression stockings, and mobilization. Vena cava filters may also be considered. These are filters that are inserted through the jugular vein or the femoral veins, and they are advised or can be considered in patients with recently diagnosed embolism in the peripartum period or prior to surgery while they are off anticoagulants, or in patients who develop embolism despite being on heparin, or in patients who have a massive embolus but are not candidates for thrombolysis. And then for maintenance therapy, stable women receiving therapeutic lower molecular weight heparin for treatment should be taught to self-administer injections, and they can be managed as outpatients. And the duration of the therapy will continue for the duration of the pregnancy, and it's advised then to continue at least 6 weeks postnatally with a total treatment time of at least 3 months. And following a DVT, to prevent complication called post-thrombotic syndrome, graduated elastic stockings should be worn throughout the pregnancy. In looking at the management of labor and delivery for patients on therapeutic anticoagulation, it's important to remember that it poses a risk of bleeding during this time, and therefore all women who are on antepartum anticoagulation should have a delivery plan. The mode of delivery will be determined by the obstetric indication, and it's important to advise patients to discontinue therapeutic anticoagulation at the time of at the first signs of labor, at the first sign of labor. And low molecular weight heparins need to be continued or discontinued 24 hours prior to delivery or regional anesthesia. And there is also a role for planned elective births, for example, through induction of labor, to optimize the anticoagulation-free interval around labor and delivery. And it can also be advised to switch patients from lower molecular weight heparin to unfractionated heparin closer to the time. And this again will reduce the time without anticoagulation. And the benefit of using unfractionated heparin is that it can be discontinued 4 to 6 hours before delivery or use of regional anesthesia. And just again, on regional anesthesia, it can be safely used if therapeutic doses have been stopped for a sufficient period of time. But prior to this, if analgesia is needed in labor, alternative methods should be considered, such as Entonox, opioids, fentanyl infusions, and so forth. But if a Caesar is required before there's been sufficient time, it will need to be done under general anesthesia. The RCOG further recommends that at Caesar, wound drains be inserted and the skin be closed with interrupted stitches to allow free drainage of potential hematomas that may occur. And then post-delivery, anticoagulation is recommenced 4 to 6 hours after vaginal delivery or 6 to 12 hours after cesarean delivery. And that is in the absence of postpartum hemorrhage and regional anesthesia. But if an epidural catheter was placed, the dose of clexane, for example, should be given 4 hours after the catheter is removed. And as we mentioned before, these patients should be monitored for development of a spinal hematoma. So for postpartum treatment, the options are to either keep the patient on the same dose, on the same lower molecular weight heparin that they were getting, or to switch them over to an oral anticoagulant. One of the reasons would be because of the difficulty in administering or the challenges administering the subcutaneous doses of the clexane and the costs involved. If patients are switched to warfarin, the initial dose is 5 to 10 milligrams, and it's given simultaneously with therapeutic doses of heparin. And the reason for continuing the heparin will be to avoid a paradoxical thrombosis that occurs when using warfarin alone. So therapeutic doses of heparin will be maintained until the INR is therapeutic for 2 consecutive days. So subsequent doses will then be titrated against the INR to achieve a range of 2 to 3. And it's very important to consider drug-to-drug interactions that may affect the INR, such as tramadol for post-Caesar patient. On the 19th of May of this year, the SAPRA issued a medicine safety alert on the harmful drug-drug interactions between warfarin and tramadol, which leads to increased INR and severe bleeding, which may be life-threatening. And then in terms of breastfeeding, it is safe, to advise mothers to breastfeed if they're on low molecular weight heparins or warfarin. But if they're on the direct oral anticoagulants, breastfeeding should be avoided. In terms of contraception, the copper IUD can be used with no restriction, but the combined hormonal contraceptives should be avoided, should not be used because of the inherent risk of increasing the risk of VTE. And then the other methods, their use will depend on when the VTE was diagnosed. If it's an acute thromboembolic event, they are category 3 and should not usually be recommended. But if it's only a history of VTE or if treatment has already been established for quite some time, then they can be considered. And then for patient follow-up, post-delivery, it should ideally be at an outpatient clinic with a physician or hematology input, and repeat imaging may be required before discontinuing treatment to assess the continuing risk of thrombosis and the need for ongoing treatment. And in terms of thrombophilia screening, it may be done, but as we said earlier on, after anticoagulant therapy has ceased, and only if the result will affect future management plans. And then these patients should be seen at a pre-pregnancy clinic to plan for thromboprophylaxis in the next pregnancy. And then as a final word, pregnancy-related venous thromboembolic events are important, preventable causes of morbidity and mortality worldwide and in our setting, as we saw with the latest updates. And all pregnant women should therefore be evaluated at the different stages of their pregnancy and appropriate preventative steps taken. And it's important to remember and understand that because managing these patients can be complex, a multidisciplinary team approach can be taken, considering all the factors that the patient may present with.
Thank you, Dr. Maka, for that well-researched and well-presented topic. I'll take questions and comment from the floor. I don't know, Prof is pointing at Maureen and Maureen is pointing at Prof, so. Okay. Dr. Moran.
Yeah, this is a very important topic. I think I missed the very start, but it sounds like you were presenting the Saving Mothers findings. Is that right?
Yes.
Which have recently, nationally and in KZN, thrombosis has come up as, or pulmonary embolism basically has come up as the number 5 cause of maternal mortality. So it is a concern, and just from speaking to different units around the province, it seems there's a general agreement that there are more cases of pulmonary embolus in pregnancy, or especially post-delivery, than there used to be, even in patients who didn't have a Caesar sometimes. And there have also been cases after gynae cases. Even we've had some cases of women who died after ectopic pregnancy, but then they died from pulmonary embolus. So it's a concern. But the problem is, what do we, well, the first question is, why are we having an increase? And maybe it's important to consider possible reasons. And I think I'll mention them in no particular order. Firstly, there seems to be a lot of use of tranexamic acid compared to before, around the time of delivery and around the time of Caesar. And I think we have to be careful about that, because it is a drug that is designed to cause thrombosis, basically. We must be strict about sticking to guidelines with regard to tranexamic acid. First of all, there's no indication to give it prophylactically around cesarean section. Evidence doesn't support that. Secondly, the only dose that has been shown in evidence to be effective for preventing postpartum hemorrhage, or not for preventing, for treating postpartum hemorrhage, is a dose of 1 gram IV. That is the dose that is supposed to be given. But I've seen that in a lot of places, people are giving 1.5 grams IV, or even we've seen cases of 3 grams. So let's not deviate from what there's evidence for when you have a drug that has potential dangers. So that's the first point. The second point is COVID. COVID happened, and we seem to have seen this increase in thrombosis after that. I think most pregnant women have had COVID that we see, and we know that COVID did cause some kind of pathology for the blood vessels and increased thrombosis. That was one of the reasons why people died during COVID. But it may be that there's an ongoing increased risk, especially if you add a factor like pregnancy coming in, which is, encourages thrombosis anyway. So is it a sort of long-term effect that we're seeing now of the COVID? And then, of course, there's like the ever-increasing obesity that we see. So there are quite a few reasons why there might be an increase. But the big issue is, what do we do about it? And I just want to quote here, this is a recent sort of article by Professor Chauke from WITS. It is important to note that there is currently no universal consensus regarding the screening of pregnant women at risk of venous thromboembolism, the specific groups that should receive pharmacological prophylaxis, as well as the appropriate dosage, timing, and duration of treatment during pregnancy. So we've got all these owing to a lack of robust evidence. So consequently, various guidelines and recommendations exist, all of which are based on expert opinion. So that's really the problem that we have. What do we actually do? And I think when people are focusing on this topic and giving advice, you must give thromboprophylaxis here and there, they're very much focusing on the issue of the outcome of thrombosis. But I think we should be looking at all possible outcomes, like death from any cause or morbidity from any cause. So you have to weigh the risk of thrombosis against the risk of hemorrhage, which, by the way, is much more common cause of maternal death than thrombosis. And even, just for example, recently there was a hospital that reported they're having a whole spate of wound sepsis after Caesar. And they didn't know what was the cause and what can be done about it. One of the questions I asked is, did these patients get thromboprophylaxis? Because wound hematoma is the common cause of wound sepsis. So, you have to think about all these possible consequences when you don't really have evidence-based guidelines. But having said that, definitely we probably need to be more vigilant about risk factors and to be probably more liberal, if I can put that term, in where we use thromboprophylaxis. If we look at the national guidelines now, they basically say you should give it for every elective season. I don't think we're doing it, but that's what the guidelines are now saying. You know, what I would say is at least every season, every emergency season, not like the elective season, every season that you do, we're supposed to be doing surgical safety checklist. And the third component of that is at the end of the operation. And one of the questions there is, should we be giving thromboprophylaxis? So every season that is done, that should be a discussion in the theatre room at the end of the operation, based on pre-existing risk factors and anything that happened during the operation. So I'm not sure if that is a routine thing that's happening at the end of every season, where anaesthetists, surgeon discuss, does this patient need thromboprophylaxis? Because that's supposed to be done anyway. And then the last point I just want to make is, you know, most of these guidelines say you should give thromboprophylaxis for 5 days or more after a season. It's not practical in our setting because we're discharging the patient on day 2 or day 3 post-season. So straight away, there's a kind of a conflict between what's in the guidelines and what we can do. I think we should be looking much more carefully at the option of the thromboembolic disease stockings, because that's something we don't seem to use much. And when I've asked about it, people say, no, it's only the physiotherapist who's allowed to prescribe that, which seems quite ridiculous. What are the costs of the stockings? And you know, is there any evidence to compare using stockings versus using 5 days of thromboprophylaxis, etc.? If we're going to be discharging patients early, then maybe it would be good to be discharging them with the stockings. The advantage of stockings, you can keep wearing them. You know, you don't have to have a new one every day. You can keep wearing them for a number of days. So I think we have national guidelines in the EML and in the new maternity care guidelines. So one can look at that and take note of it. But I think there's still a lot of thinking that needs to be done about what's the best sort of way forward to minimize the occurrence of thrombotic morbidity while not increasing the risks that may be associated with too liberal use of anticoagulation or thromboprophylaxis. Sorry, that is quite a long comment.
Thank you. Thank you, Dr. Moran. Those were important comments, so we appreciate them. I'll take one more question if possible. If there's any burning questions from the audience, we have run out of time. Okay, it's out. I don't know if there's any questions or comments from the online audience. I'm unable to view. If not, thank you, Dr. Makwa, for excellent presentation. Okay, Prof wants to give her last.
Good morning and thanks to the representative. Next week, the HPCSA is on the premises. They are coming to accredit our postgrad program.